Perfect.
Thank you. So Guillermo, it's all yours.
Thank you. Good morning, good afternoon, and thank you for joining us, Reunión Latina Training Institute virtual again. I'm sure all of us are aware that we have been dealing for over 11 months, 12 months, depending on where you are, with this unprecedented public health crisis. And it's important to come together and to continue building a robust response. We can see the finish line, but we have to stay disciplined and promote vaccination, prevention, and so on to respond to this crisis. But once again, thank you for joining us. Por favor, si quisieran escuchar las presentaciones que van a ser muy importantes en español, les pedimos por favor que toquen el logotipo donde dice Interpretation para poder tener la interpretación al español. Tocan ese botoncito y usted escoge la lengua. Y solo son dos opciones, inglés o español. Entonces, por favor, toque a la parte de abajo, a su mano derecha, un logotipo que dice Interpretation, que significa interpretación, para que puedan escucharnos. And we're so honored and happy to, again, come together on 2021. And we are very, very honored to have Dr. Paulina Rebolledo from a very important partner for all of us, and someone that is truly committed to address not only many health issues in our communities, but especially she's going to do a presentation about the impact on COVID. Dr. Rebolledo is an assistant professor of medicine and global health at the Division of Infectious Disease at Emory University School of Medicine and Rollins School of Public Health in beautiful Georgia. All yours, Dr. Paulina. Welcome. Gracias. Bienvenida.
Thank you. Thank you, everyone, for the ability to be here today. Let me share my screen. Okay, so good morning, everyone. Buenos días, buenas tardes. Today, I'd like to share some insight into how systemic racism and inequities and other factors impact the health and well-being of Latinos living in the United States, and how COVID-19 has exacerbated or shed light on some of these disparities. So for our learning objectives today, I'd like to describe the impact of COVID-19 among Latin communities in the United States. Also describe the social and structural factors that have placed our communities at an increased risk for all different measures of morbidity and mortality for COVID. Provide some historical overview on how some of these factors have been going on for decades, and they have resulted in other health inequities in our population, and discuss some potential solutions on how we can start to or continue to promote health equity among our communities in the United States. So we know that COVID-19 throughout the past year has impacted every single community in the United States and on a global scale. But we know that if we look specifically at Latinos, we make up 19% of the population, yet we have accounted for 35% of all of the COVID deaths and close to 40% of those deaths. So I want you to keep that messaging as we go through different aspects of the presentation and think about how we can tackle all of from different angles. So when we look more closely on how Hispanics have compared to non-Hispanics, we see that we have represented 2 times as likely to have COVID, 3 times as likely to result in hospitalization, and importantly, 2.3 times as likely to result in death if we were to become a COVID case. So these are the trends that we can see over time, and this the red arrow indicates the Hispanic population, and we can see that since early the early days of the pandemic, there was an important trend where Latinos were representing an important percentage of the weekly rates of COVID. And you can see how even more recently at the beginning of the year, sort of like our second wave, we saw how this trend continued to stay true. And now we can see how with the impact of vaccination, we're starting to see a significant drop. But again, sort of like the importance of the overrepresentation of Latinos among weekly cases. So when we look at or we think about how we've evolved through the last year, we can think about, it's important to think that there's been a diversity in geography. And for those states that represent, that have a large proportion of Latinos living in their population, in some instances, so for example, we're looking here at California and Texas, we see that during the summer of 2020, Latinos represented more than 50% of the deaths in those states, despite having a lower representation for the overall population. And then looking more closely at what COVID has done on a household level and how it has had implications for economic well-being of these communities. This data from the Urban Institute shows that at the initiation of the pandemic, so when we were first starting to shelter in place, Hispanic individuals, regardless of whether they were non-citizen or citizens, they had an important impact on their ability to continue to be part of the workforce, with Hispanics that were not citizens losing about 70% of their jobs, compared to Hispanics who were members of who were citizens, but still had an important impact on their overall ability to continue to be in the workforce. Looking more closely on other measures of economic stability and economic well-being, we see that during this time period, again, early on in the pandemic, Latinos, regardless of whether they were citizens or non-citizens, they more than 40% of them had to cut back on spending on food, so leading to food insecurity. And if you look at here, also an important point, I mean, all of these measures are important for the health and well-being of households, but over more than 1/3 of Latinos had to use up all of their savings given the unexpected impact of COVID on their daily lives. So why are Latinos so disproportionately impacted by COVID-19? And you are probably all aware of this and have seen this with the communities and the patients that you serve. And we tend to be communities that are intergenerational. We tend to live together. We have multiple members of our household living close by, and we tend to be close and rely on community for a lot of our well-being and our social capital. But again, this is not necessarily the reason why we have been disproportionately impacted, or the sole reason. A lot of the importance or the impact has been due to a lot of racial and ethnic inequities that have existed for quite some time, and that are driven by a broader underlying structural and systemic barriers, including racism and discrimination. And so in the next piece of the presentation, I'd like to dig more deeply into some of those. So this is a study that was published in July of 2020. And the reason why I show this study is because there was a lot of talk in the early days of the pandemic, or it even still goes on, that the reason why members of the Latin community were impacted more by COVID was because they tended to have a high proportion of comorbidities. And while that may hold true in some instances, it's also important to realize that, for example, at the height of the pandemic, when shelter in place was ongoing in places like San Francisco, the point prevalence for this study of COVID-19 among Latin populations was 20 times higher than for non-Latin participants. Again, just sort of like emphasizing that important representation or over-representation for the Latin community among COVID cases. For this study, there was no association between individual comorbid conditions and any recent positivity. So at least for this cohort, and there's been others as well, there was not a higher incidence of diabetes or hypertension. More than 60% of those individuals who tested positive for COVID tended to be young men. They were living in poverty. They were working frontline service jobs, and they were the sole providers for their families in many instances. So again, highlighting that it's not all about other health conditions. There's a lot of deep-rooted inequities that have perpetuated and continue to increase that overall cycle of inequity. So what about employment time? So we know that our populations are overrepresented in the essential service industries, whether that be food and beverage, restauranting, food processing, housekeeping, and maintenance. And for a lot of our community, and particularly for these types of employments, social distancing and how that was early on known to be an important measure on how to mitigate the disease became a commodity, right? Because it's not possible when one is working in a lot of these services where the physical spacing is not possible. So again, that ability and that privilege to be able to stay from home was not feasible for many individuals. So this study highlights, it was a study done among frontline workers in the food industry, and it was a 21-state study that included close to 10,000 workers, those who were in the animal slaughtering and processing industry between April and May of 2020. And what they saw in this study is that if you look at here, the different bars representing race and ethnicity, 56% of the cases in those food processing plants were of Latin ethnicity. And also there tends to be an important representation of the younger groups. And if we remember what we spoke a little bit, a few slides ago from that study in San Francisco, again, that representation in the working industry tends to be younger males, younger females, again, of Latin, or describing themselves as Latin ethnicity. So just emphasizing again how another example about this overrepresentation. So in terms of the risk that the employment per se has also caused is that employers in many of these jobs, they tend to fail to provide basic protection. So there's still a lot of, I still hear from like patients where they're not necessarily handed out like masks consistently. We know early in the pandemic that PPE was very rationed. And so employers were not necessarily felt empowered to provide these or felt the obligation to do so. So reliance on a lot of community-based organizations was important. Usually the employers do not provide health insurance. They lack paid sick leave. There's very limited childcare options. So again, forcing that inability to stay home, to take care of children if they're having to go to these frontline working jobs. And then the additional risk that is just also posed by the distance from where they work. So having to rely on public transportations and buses in the cases of farm workers. The other aspect that's important is housing segregation. So a lot of the urban metropolitan areas that some of us know as barrios or border colonias, that are newer destinations where people may have been immigrating, they have less social support. There's a lot of hardships that have to do with securing housing, whether that be due to undocumented status, the language barrier, and again, just the drivers of systemic racism into these neighborhoods. The importance I mentioned of multi-generational families and why that has caused important implications. And so there's various studies that show, and one from the Pew Institute, that overall 27% of Latinos tend to live in multi-generational households, where compared to 16% of whites. So again, if there is one individual who's obviously like working and then coming home with members of the household who are older and are at higher risk per se for COVID, then again, just perpetuating that cycle of transmission. And this has resulted in families and roommates congregating in small spaces within segregated neighborhoods. So I'd like to provide just an example and something that I'm sure a lot of you saw during the early days and continue through the pandemic. And this is from some of a story that I kept on seeing recurring among my patients. And so this is just an example of a 34-year-old Hispanic male who works in construction, who's one of my patients, who lives with multiple co-workers during the week. He had lack of PPE at work. He relied on public transportation. So a lot of those social mitigation strategies that were early on identified as important are not able to be met. And then that resulted that when he comes home over the weekend to stay with his family who has been sheltering in place, there was increased transmission, and that resulted in hospitalization of multiple family members. So as I was seeing in the hospital from taking care of COVID patients, as well as from approaching them for different therapeutic research studies, we saw that whole families, whole nuclei of friends and families were being impacted due to COVID. So the other important implication are policies and how these have is how perpetuated the transmission and the impact that COVID has had. And we know that from certain intensified law enforcement immigration practices that had been ongoing from previous administrations, this constant fear of deportation and detainment in ICE facilities and the family separation. This had led to people fearing going to COVID-19 testing sites. So initially, people feared whether they may be arrested at a COVID if they sought COVID testing sites, whether this could be counted against them sort of as a public charge. And again, the fear of sharing personal health information. There was a lot of sites that required providing either a social security, providing an address, and that address was done more for contract tracing. But again, that information was not communicating, and the messaging around the importance of that was not conveyed adequately to the community. So just perpetuating this fear of being detained or being deported. The ineligibility of undocumented individuals for public health funded plans such as the Affordable Care Act, Medicaid, and Medicare, again, resulting in like limited access, people waiting for days and maybe even weeks at home with COVID before accessing or wanting to come into the hospital. So that just their mortality and their morbidity was a lot more pronounced when they finally came in. And what I was mentioning about the public charge rule and how this made members of the community refrain from going to clinics or hospitals for fear of retaliation in the future with regarding to their U.S. Residency or citizenship status. And then for inability for individuals to obtain a driver's license for undocumented individuals, and again, depending on public transportation, having to get to testing sites, having to get to vaccination sites that are far away from where they currently live. So again, this is not new to COVID. You can see here this data from 2019 that we were already looking at how Latinos first felt regarding the situation and how they felt that it was already like getting worse. So worse. So this is even before COVID. So again, just sort of like emphasizing that this is not something new. COVID was not the trigger for this. The triggers had been ongoing for many years, and and COVID was more just, you know, the match that essentially lit the fire. We know that from all of these factors are important in terms of systemic racism. We know that communities live in poverty. They have, again, limited access to healthcare, disproportionate representation in frontline jobs, their lack of employment protections, this housing segregation, and living with multi-generational members, and the policies and sentiments that impacted their ability to access testing sites or other healthcare at a in a timely fashion, just overall increasing the COVID impact on the Latin community. So some of the things that we did and we know occurred across different sites is partner with community-based organizations. And so testing venues were one of those early signs where we sort of came together from representation in universities, from people in the community, volunteers, in order to provide on-site registration to secure spaces that the community told us where we should go, instead of expecting individuals to come to areas that we may think are convenient. So making them accessible, providing community support, having materials in Spanish, and again, just overall emphasizing that the way to engage the population is for us to come to them and create these spaces where they feel that they can trust the individuals at whatever service they are being provided, and that importance of relying and listening to our local community-based organizations. So moving on to vaccines, there's an important point that I wanted to mention about how there has never been such an important time in order to ensure the representation of racial and ethnic minorities in clinical trials. And this is not only about COVID, this is just in general thinking about there should always be intentional inclusion and intentional representation of individuals who are largely affected by any type of disease. And why is this important? We obviously know that there's biological differences and how different races or ethnicities may respond to different treatments. It's important to ensure that there's safety for all and that the effectiveness is across populations. And this will increase the confidence in science and confidence in the medical establishment. So when members of an underrepresented community see or know that there were individuals from their community that participated in a clinical trial for the COVID vaccine or for a different type of vaccine, again, it starts to normalize the process process, and they see that they were included in the early stages, and that fear or that lack of confidence in the research and the research process, we may be able to start to change that perspective. The target enrollment, it should always be populations, again, at risk for infection. And clinical trials in general have historically lacked inclusion of racial and minority groups. And this, because of this, in the early 90s, the NIH passed this Revitalization Act, mandating the inclusion of women and minorities. But we have not yet done so well in terms of doing this. And so this is a study from 2021 that looked at the participation for adult population in vaccine clinical trials, again, not COVID, just overall. And it compared how this data looked in 2011 and 2018. And you can see that down here in this in the red circle, the Hispanic or Latino individuals only accounted for 11% of those who participated in clinical trials, when in fact they made 16% of the population in the early 2000s, the early 2010, and close to 19% in 2018. So again, that we emphasizing that we really have a lot of work to do in terms of really being inclusive and being equitable in our recruitment of clinical trial participants. So what we did at Emory, and I know has been done at a lot of different sites, is that our mission should really be in the intentional recruitment and participation of priority populations. And what does this really mean? It means, again, our really placing an important emphasis on community outreach, having targeted recruitment approaches for monolingual and bilingual participants. There should be representation of racial and ethnic minorities on study teams, including investigators, so that people, when they come, to the site, they can see people who look like them, who talk like them, who they can relate to. And this led, at least for us, on the Moderna phase 3 study, that we were one of the highest enrolling sites for Black and Latin participants. So again, at least my commitment and my involvement in research is very tied to increasing our representation and making sure that the clinical trials are available if racial and ethnic minorities want to participate. So where are we currently with COVID vaccines? And so this is a map of the United States as of April 27. And you can see here, these are like the different percentages of vaccinations that have occurred, or the different representation for members of the Latin community for each state. And you can see that we're in some states, we're obviously doing better, but even, for example, for California, where we're around like 25%, Latinos represent 40% of the population. You can see I included Georgia here for my own home. But again, that we're still lagging behind in terms of the population. And the same thing can be said for a lot of the states in the East and the South. So the reassuring aspect is that there has been a lot of talk about Latino community being hesitant and not wanting to get vaccinations. But what we can see is that there's a lot of problems to access. The enthusiasm, as shown by this survey from the Kaiser Family Foundation, shows that the enthusiasm for receiving a COVID vaccine continues to grow among the Latin community. And so this, for us, has led to creating equitable initiatives closer to home, where we this message of like community vaccinating communities. So eliciting volunteers, medical student volunteers who are Latinos, from public health, from different faculty. So again, that we're able to provide and speak to our participants on site, answer any questions they may be. And again, an important piece of this is talking to the community and understanding what their reservations may be, because what I can think as a physician may be a reason why people don't want to get vaccinated is not necessarily the case. So we really need to find opportunities to create a bidirectional dialogue where we can continue to hear what the community thinks and then address their concerns and their questions. So what about other illnesses? So it's the same factors, different illnesses. Here, I just like to illustrate a few other inequities that exist among other diseases for our Latin community. And we know that there's a disproportionate risk of diabetes and related complications. Importantly, to everyone in this, for their work that they do in HIV/AIDS, is there's a disproportionate risk of acquisition and progression to AIDS. People presenting, members of the Latin community presenting very late to the hospital. And then there's a lot of the the impacts of chronic stress and the stigma, this just overall trauma that has been related to the passage of immigration-related legislature. And while there are starting to see some important changes, a lot of the damage has been done. And so there's a lot of low self-esteem, anxiety, of depression, feeling of not belonging that we really have to work hard at combating. And for Latina moms, we know that they, in general, as a population, have limited prenatal access due to challenges or fear of accessing the healthcare. One important, I guess it's a good example about how policy implications affect individuals and how we can make a difference. And this is just from what the Affordable Care Act data from 2010 to 2018 of the rates of uninsurance. And we see here that for Hispanic individuals, when the Affordable Care Act, we made an important debt in, or I guess dent in the impact on the percent of uninsured. So we went from like 33% to close to 18%. This was in 2018. So everything, the things that we met, the things that we think about, what we legislate for, these implications will have important, they will have important implications to improve the well-being of the community. Again, just some of the other examples on how the DACA, the public charge, and how all of these like legislations have had important emotional and impact and financial stress. Their fear of being treated different for speaking Spanish, exposing their immigration status, and a lot of dependence on free clinics or community-based clinics, which had an important implications in the beginning of the pandemic and still has when a lot of these were closed or they have not been able to recover, or they don't have those services as telehealth in order to be able to continue to retain individuals in care. So what are some of the potential strategies that we can do to overcome these social and structural factors? So again, the importance of representation matters. So hiring Latin staff, including in leadership positions, when we see people that look like us and that we can look up and aspire to, that serve as role models, then that overall just, speaks to the inclusion of the place and the wanting to be open and have our representation from, really like, I guess, being actionable about the things that we say that are important. And that we should always include Latin populations in the educational and public health strategies. We should try to create or ensure and hold public health departments accountable to make them be safe space for immigrants, where there's honest and visible message so that they know that nobody's going to share personal health information. And the reason why we may ask for a telephone number or their name is, again, more to be able to either contact them, to remind them of their second dose, or for other, but this is not something that is going to be utilized against them. We should, financial investment and partnerships with local CBOs is vital. We should, and these I included some of our partners have been, in Georgia, have been instrumental in being able to reach our community and being able to carry out our testing venues, our community outreach, as well as our vaccination. And so we should utilize these opportunities and work closely together in order to empower the community and show them that where they come to us, they are able to ask any questions, that they will be safe, and that we really have their best interest in mind. There should always be the priorities, again, selection of the COVID-19 testing and vaccine sites. Some of the things that we've seen is to avoid pre-registration requirements, having flexible testing hours, and again, the importance of letting them know that they do not need an ID to be able to do these. And so it's similar themes that what we saw with testing, similar things that we've seen with HIV, just different diseases. So we should really take the opportunity to utilize everything that we learned and the mobilization on a grassroots level that we saw with COVID to be able to carry this forward and not wait until or for the next pandemic to continue to build on this. And lastly, we should really hold in organizations accountable in order to tackle the implicit bias, to provide training, both from on our organizational and individual standpoint. We should optimize data gathering to learn more about racial disparities for COVID and other diseases. And something that I know you all work very hard is that every Latin community is different. We are not a monolith, and it's important to continue to educate members outside of our community and within our community and remind ourselves that what may be applicable to one particular Latin community won't necessarily be to the other. So reinventing and continue to be open to adapting to whatever community we may be working for. And really, finally, more, this is something that I try to remind myself, is using the privilege that I have as a healthcare provider in order to really highlight the injustices that we saw with our patients and advocate for change in any way we can, starting at an individual level in an organization, and obviously as we climb up the ladder to the state and federal level. So with that, I'd like to thank you for your participation and acknowledge all of the wonderful colleagues with the local community-based organization, as well as all our volunteers, and really the engagement of the Hispanic students on every single aspect of the university to be able to come to the community, and the community for hearing us. So thank you.
Thank you so much, Dr. Rebolledo. We send greetings to you too, to you, your family, loved ones, and please send our big virtual hugs to all the folks in the School of Medicine at Emory and the School of Public Health, but everyone in Georgia that partner with you. Partnership is the way to go here. And again, I just want to highlight in terms of Puerto Rico, as all of us know, we're concerned. Over 100,000 cases, over 2,000 deaths. In Puerto Rico, a few days ago, already vaccinated, I believe 1.9 overall, but only 819,000 double vaccine. And that is like close to 26% of the population. Way to go for Puerto Rico. The slides will be shared with everybody. We're 197 attendees here. I don't know Facebook, but I will guess also we have a lot of folks connected. And we say muchas gracias, thank you. And I want to highlight that the Commission and the Hispanic Health Network has been working hard with the COVID Prevention Network. We also, under the leadership of Alianza Americas, we're working with Somos Salud. It's a partnership nationwide with Ventanillas de Salud, another important program that is home-based or partnered strongly with the Mexican network consulates throughout the US. And again, I'm sure at many local, county, state level, we're doing a lot. Please, please, please partner with your local health departments, support them, partner and follow the guidelines of the CDC, who work 24/7 to respond to this pandemic, along with the entire family of Health and Human Services. And we send good vibes and good energy, positive energy to the incoming almost a month and a half ago, Dr. Javier Becerra, the new Secretary of Health and Human Services at HHS, who also we will need to recognize. Moving forward, I just want to let everybody know that we welcome you all for this 2021 Reunión Latina Training Institute. We are folks from Texas, Puerto Rico, Illinois, Florida, California, Georgia, North Carolina, Nevada, Arizona, Maryland, Ohio, Indiana, and many other places. Probably a couple of people from Jupiter are joining us, and that is good. We're moving right now to a very powerful panel, Hispanic Latinx panel that will address the issues, health issues, especially when we talk about HIV, hepatitis, STIs, and we have a very strong panel that we welcome also. The first panelist is going to be a tremendous hero, a super hero for us. Joanne Mort is the director of the ACE Institute, the New York State ACE Institute is a center that we support, we work, because it's a model for the entire US. And we're so happy to have Joanne as the first speaker, and then we will have Dr. Ivan Melendez from Puerto Rico, and then finally we're going to have Dr. Dimitri Daskalaskis, another two superheroes for us. Let's move on, and again, we're grateful with Dr. Paulina Rebolledo for her presentation, and again, the slides will be sent to all of you. Let's begin with the first panelist. It's going to be Joanne Moore, and here we go.
health
right. Oh, go ahead.
to have on the work that we're doing. Next slide. So the slide that you see here provides some general information. In 2019, 36% of new HIV diagnoses, totaling 2,377, were among individuals between the ages of 25 and 34. The age group has represented the largest number of new diagnoses every year for the past 10 years. Additionally, also representative as among the largest number of new diagnoses every year for the past 10 years include individuals who report a history of male-to-male sexual contact, representing 54% of the individuals newly diagnosed. 80% of new HIV diagnoses are among individuals assigned as male at birth, and Black and non-Hispanic and Hispanic individuals account for 78% of persons newly diagnosed. Next slide. The slide that you see here represents individuals who identify as being Hispanic, newly diagnosed with HIV, representing the data from 2019. And most new diagnoses among Hispanic persons occurred among those who reside in New York City. There were more Hispanic males than females, again, as assigned at birth, diagnosed with HIV. The most frequently reported transmission risk was a history of male-to-male sexual contact, and about 30% of new diagnoses among individuals who identify as Hispanic represented individuals aged 30 to 39 years old. Next slide. The slide that you see here, representing men who have a history of male-to-male sexual contact, newly diagnosed with HIV by residents at diagnoses, as well as race and ethnicity, shows overall in New York State, non-Hispanic, Black, and Hispanic individuals accounted for a majority of the new diagnoses among individuals who identify as gay, bisexual, or otherwise men who have sex with men. We see differences between New York City and rest of state when this is broken down by region of residence at the time of diagnosis. Next slide. When looking at persons of trans experience by race and ethnicity, what we see are that individuals who identify as Hispanic account for the largest percentage of individuals within the transgender community, about 42%, followed by persons who identify as transgender and non-Hispanic Black, representing 39%. Transgender women account for 82% of all individuals who identify as transgender and diagnosed with HIV. 90% of individuals report sexual risk as a transmission risk group, including sex with both men and women, and 73% of individuals are between the age of 13 to 34 at the time of their diagnosis. Next slide. Hispanic persons disproportionately impacted by sexually transmitted infections. This data reflects New York State, does not include New York City, and also shows that in the last 10 consecutive years, sexually transmitted infections increased among Hispanic persons since, again, 2010. In 2019, over 7,900 individuals who identified as being Hispanic were diagnosed with a sexually transmitted infection. Again, we continue to see disproportionate impact by STIs along with other populations and communities. Hispanic persons are 2 times more affected by gonorrhea and chlamydia, 3 times more affected by early syphilis as compared to white and non-Hispanic persons. However, we are happy to say that treatment rates continue to be well above 90% among Hispanic individuals. 63% of the STIs diagnosed among individuals are individuals younger than 26 years old. And this percentage is slightly lower than the average in New York State, which is about 64.6%. We are continuing to be committed to our work on sexually transmitted infections as far as education, awareness, treatment, and continued prevention interventions. Next slide. Hepatitis C, the slide that you see here highlights the hepatitis C care continuum from linkage to care all the way to cure. There's no significant difference that's seen among individuals who identify as Hispanic as compared to other races and ethnicities when we look across this care continuum. 86% of individuals who identify as Hispanic were found to be linked to providers for hepatitis C treatment. Of the individuals linked, 74% began treatment, 90% completed treatment, and 98% of individuals were cured. Next slide. All syringe exchange programs, which is the SEP, and HUB, which represents Drug User Health Hub, participants are reflected here by their race and ethnicity. The graph shows that 41% of people who utilize these services in New York State do identify as being Hispanic, and the majority of participants, about 90%, reside within New York City. In New York City, most individuals utilizing the SEPs and the HUBs, about 55% identified as being Hispanic, with 75% being male, 21% being female, and an additional 4% of individuals identifying as being transgender. The majority of individuals were 35 years old and older. Next slide. So just briefly to touch on COVID-19, certainly the last 14 months have been a challenge for all of us. And what we wanted to show here were the interventions that have taken place, with over 50 million New Yorkers being tested, 2 million New Yorkers being diagnosed with COVID-19, about 90,000 individuals being hospitalized, and unfortunately around 42,000 individuals passing away. I say unfortunately, especially recognizing that for many of you participating today, I know that among that group are individuals that are your family, are your colleagues, and your friends. Controlling for age, sex, and region, we spent significant time trying to understand the impact of COVID-19 on persons who are living with diagnosed HIV. What we found is that as far as diagnosis, there was no distinction. Individuals who are living with HIV were diagnosed at about the same rate as individuals not diagnosed with HIV. We also found the same as it related to hospitalization and mortality rates. However, the one thing that I do want to say is that among persons who are diagnosed with HIV, the hospitalization rate appeared to be about 40% higher than the general population. Some of what contributed to this included low CD4 counts as well as high viral loads, and higher hospitalization ultimately drove a 25% higher overall mortality rate among persons living with HIV. Next slide. In the past year, in addition to all else that we have dealt with, we continued with the conversation of racial and social justice impacted by systemic and other forms of racism. In fact, these became very centralized priority discussions. Leaders nationally and certainly within our state referenced racism as being a public health issue, and health disparities moved to center stage. We saw companies begin to bring on and provide titles to senior staff members that deemed individuals responsible for the achievement of equity and responsibility for addressing historic and rooted racism in organizations. All very good. My question to all of you, though, is it good enough? How do we put intention into action? Action into outcomes. Outcomes that result in rooted change. Change that impacts the culture and the expectation of where we work, where we live, and where we play. Today, we are together with a common intention and to gain information for ourselves that we will apply to the work that we do as we serve others. So I ask yourself as you participate in today's discussions to challenge yourself with this question: how will I impact change? Next slide. So the information you have here is simply how you can reach me. And I want to say that in the few minutes that you've allowed for me to be present, I'm so very grateful. I want to extend my thanks, extend my appreciation to everyone who has made the conference possible, to my friend, to my colleague, to my partner, Guillermo, Chacón, to everyone at the Latino Commission on AIDS. I thank you. And to all of you, I hope you accept my challenge, and I hope that the information I share to see where we are with the most recent data available, being 2019, will help you as you are in your discussions to think about how do we continue to move forward with some of the gains that we made in 2019? How do we identify and acknowledge some of the challenges that the last 14 months may have presented to the gains we made? Given the many steps necessary to respond and to maintain safety during this time of COVID? And how do we collectively continue to support one another as we look to return back to our work, return back to and continue to provide support around the health and wellness of the people that we serve? Thank you.
Thank you, Joanne. Again, I want to emphasize the partnership. We're very blessed to work closely with our local county, but especially the state health department, in particular the ACE Institute. Please send our regards and admiration and respect to everyone that is around you and work closely, because we know that all of you have been also responding to the impact of COVID in our state, and we are very grateful for that. I'm sorry, apologies for the little boo-boo on sound was on our end. Apologies for that. And I will only request for the next two speakers to speak a little slow, because we have a Spanish interpretation, and it's easier for folks that are doing simultaneous Spanish interpretation to follow you. But let's welcome with open arms another champion of our community, a personal friend, a hero, someone that we love, respect, admire him and everybody around him. And also because Dr. Ivan Melendez Rivera is also the Chief Medical and Operating Officer at Centro Ararat, someone that we work very closely with in Puerto Rico. We welcome you with a virtual hug, and we pass the mic to you. Thank you for joining us today.
Thank you, Guillermo, for this introduction, and thank you for the opportunity to share the time here. Let me get my presentation. Screen one. Yes, it's this one. Share. Okay. Okay. Is everyone able to see the presentation of now? I hope. Okay. So, okay. Okay, so thank you very much for the opportunity to do this presentation. Let me start by introduce my institution here. Centro Ararat is a non-profit community-based organization serving more than 5,000 lives, including over 1,000 HIV-positive patients and almost 800 clients in PrEP. We have 4 primary care clinics and 2 specializing clinics, including the largest transgender primary care clinic in Puerto Rico. Puerto Rico is the biggest of the small Caribbean island. As someone said, an island surrounded by water, but we are really surrounded by beautiful beaches and a beautiful history. The current COVID-19 pandemic is only the most recent to disrupt our local healthcare system. Over the last decade, Puerto Rico has undergone a public and private financial crisis, immigration to the U.S. of more than 10% of its population, primarily young and healthy, and a devastating Hurricane Maria in 2017, and also more than 10,000 earthquakes since December 2019. However, the effect of the current emergency and imposed social distancing measure has only exacerbated the underlying susceptibility of the vulnerable population, especially the LGBT community, who made better during this other recent disaster. The following table presents data per month of the total people served by the PASS line, that's the crisis line by the Department of Health, from 2016 to 2020. Notice the decrease of the call of September 2017 at the end of October 2017 too, due to no communication service caused the Maria hurricane. and 3 times increase in the call during the earthquakes at the beginning of 2020 and up to 10 times during the pandemic in 2020. In the past 3 years, we have found we have 4 major disasters. In the face of all this, our emotional vulnerability has been heightened. Now, we have a collective issue of mental health that is being compounded by the lack of resources like child care or the fear to get infected when you live in home. As Puerto Rican, we are very caring. We believe in the solidarity, but we do have a mental health problem. 2020 census demonstrated that 3.2 million persons live in the island, a population change of almost 12% less compared to 2010. Puerto Rico became the jurisdiction with the greatest loss of inhabitants, followed remotely by West Virginia. We returned to the same population in 1980. How we returned also to the music of that time too. Only with 5 cases confirmed of COVID-19 in Puerto Rico, the governor of Puerto Rico at that time, Wanda Vázquez, declared a total lockdown starting at 9 p.m. on March 15, 2020. Up to date, Puerto Rico had more than 166,000 cases of COVID, with 2,300 people died from COVID. Only 24% of our population is fully vaccinated, and the vaccination rate right now is decreasing. There are several disruptions in healthcare. Many clinics closed at the start of the pandemic. Those that remain open struggle for acquiring personal protective equipment, modify flow and layout, and limiting the people who attend the clinic just to get the social distancing. Puerto Rico is an overregulated island at the healthcare system. Before the pandemic in Puerto Rico, physicians required a specific license to use telemedicine for patient care. Psychologists are not allowed to use telemedicine for care. All controlled substance requires a face-to-face evaluation before to print a hard copy of that prescription. And also, pharmacists are not allowed to deliver medication by mails. Labs need to be in a hard copy also to be accepted by the different laboratories. An emergency declaration allowed the executive order that allowed the physicians and also psychologists and nutritionists and other health professionals to use the telemedicine for do their work. Also, right now, physicians can send prescription by lab, by fax, and even by WhatsApp. Prevention and mitigation program also have another side. The stay-at-home orders increase the intra-family violence, domestic violence, and also the elderly abuse. The venues closed eliminate the working hours, also cut back nighttime outreach. There's a lot of lost jobs, and also at that time, loss of health insurance provided by employer. Medication shortages happen because problem with logistics and distribution, because we are an island. COVID-19 is a new pathogen with the same disparity as HIV virus. Latinx community has been disproportionately affected by COVID-19 as well as HIV due to the disparity in the social determinant of health. Consequently, all that will have a direct negative implication at the end of HIV epidemic plan. At December 31st, 2020, Puerto Rico had over 16,000 people living with HIV. The HIV incident has been gradually decreasing in the past couple of years. This graph shows how in 2017 and 2020, the new cases per year are far below the trend line. In 2017, services were interrupted by Hurricane Maria, and in 2020, by the pandemic. There are a couple of factors that contribute to the decrease in the diagnosis. One is the decrease of HIV testing service, and another specific to the 2020, the physical distancing. To have an idea, how HIV testing survey were affected during 2020, we plot the same graph what we observed in the HIV test at Central Arab. As a sharp decrease we observed, we have 1,800 tests performed in 2019 compared to less than 1,000 performed in 2020. Almost one-fold decrease. That is the similar proportional what we observed in the reported new HIV cases. PrEP and PEP also are impact across the continuum of care. We have to moving forward looking awareness of risk of HIV and start people on PrEP to get the population who are already on PrEP adhere to the medication and retaining PrEP. Having the biggest PrEP clinic in Puerto Rico, we showed the enrollments per quarter term in 2020. After the lockdown, the graphs present that how PrEP enrollment significantly declined from 82 in the first quarter to 19 in the second quarter. We also can observe that how the enrollment bounced back in the third and fourth quarters after the clinic has all the service meet the population needs during the pandemic, like home testing, medication delivered at home, and telehealth. You can also observe that a trend of patients who stopped taking PrEP during the 2020. There is a considerable number of patients who stopped PrEP right after the lockdown. The main reason given by patients to stop PrEP was they are no longer need PrEP and they are not having sex due to physical distance. Well, there's not official number of STI or hepatitis C from Puerto Rico area from 2020 available right now. But we can mention the challenge that we confronted at that time. First, there was a challenge in drug availability, especially to identify alternatives to provide oral regimen instant to use intramuscular regimen just to reduce the people who go to the clinic. But there are also good news. Hepatitis C treatments was available right now and started at the time of the pandemic for more infected patients who are participants of the government insurance. There's also a big impact in the pandemic regarding the opioid use epidemic. Before the pandemic, methadone was dispensed daily. The prescription of buprenorphine required a negative toxicology urine test and a face-to-face evaluation by the physician. Executive orders allowed buprenorphine prescription to be right without toxicological test, and also Puerto Rico developed a take-home program for methadone, allowing a weekly pickup. Obviously, that's also caused some problem with methadone on the street. As an institution, we have a lot of success, and I'm just going to mention some. We use social media to promote and allow the request for HIV home test kit and condom. We sent more than 1,500 kits in 4 months. We also deliver all HIV and PrEP medication to our clients' home in person, by a local carrier, or by mail. I have some final notes. The first one, the pandemic is adding to the disaster, stress, anxiety, and depression. The grassroots strategies and community knowledge will be strengthened the effectiveness effort if we fully integrate this marginalized and vulnerable population to the responding of COVID pandemic. Even that there's no accountability when it's come to dealing with this kind of event, we know that the government response can be perfect, but it can be so vastly imperfect either. The government official needs to focus on establish a disaster readiness plan that addresses the long-term psychological need that come after these events. This finding call for a focused, energetic policy and programmatic response. Thank you very much for the opportunity to present just some of the data that we have from Puerto Rico. Here is my contact information for the presentation.
Thank you so much, Dr. Ivan Melendez Rivera. And we will have a small section for Q&A. If you could bear with us, that would be great. And the slides also will be shared with all the participants. We have been between 198 to 206 people, just on Zoom, and I'm sure more in Facebook. Also, we are so grateful for your work, and please send our regards to everyone at Centro Ararat, who do an amazing job in every single site. We're grateful for that. And moving along, I have the distinguished pleasure. I want to remind all of us also that we are on the eve of the June 5th. It's going to be 40 years since HIV and AIDS was unveiled, was announced, through a publication. And then 40 years later, here we are working with the new administration to advance ending the HIV in the United States and in Puerto Rico and the U.S. Virgin Islands, the territories. Also, this next year are very important. It's the 10 years after the census. And thank you, Dr. Ivanton, to sharing, that the latest data of Census 2020 on Puerto Rico. We have many challenges. And for that reason, we need all of us to advance a new response, a more comprehensive, guided by a real investment in public health. And one of those pillars that will help us to advance is Dr. Dimitri Daskalaskis. He's the director of the division of HIV at CDC, someone that we know is a big side of his heart. He's Hispano-Latino, Hispanic, Latino, Latina. And for that, we love you. The stage is yours, Dr. Daskalaski. We're so proud to have you.
Guillermo, thank you very much. I feel like I can never, ever miss a Reunion Latina. It's a part of my year. And so I'm glad that I'm able to come in my new, and I'll say positions at the CDC, which we'll talk a little bit about as well. I'm try to share my screen and let me know if it in a moment looks like a presentation. Can you see? Okay, good. Excellent. So again, I want to thank you for the invitation. This is such an important part of my year. I love being able to be a part of the Reunion Latina. So today I'm going to give a national view with some focus on the ending the HIV epidemic program, specifically looking at U.S. Latino communities. So I'll start by sharing our overall view of data. So I'll give you a little bit of a spoiler. This is our 2018 data. Our new data and surveillance report will not be released until the end of May. So our Atlas website will have the most current available data, but I can tell you at least from 2018 that we were at a little bit under 38,000 new HIV diagnoses. 1 in 5 of all new HIV diagnoses were among women, and 69% of new HIV diagnoses were related to male-to-male sexual contact. Let me try to move this a bit. There we go. When looking specifically at HIV among Hispanic or Latino Americans in the United States and areas, they made up 27% of the new HIV diagnoses. So they're just under 38,000. Again, so 27% were among Hispanic or Latino individuals. That's about 9,800. When you look very specifically, again, the lion's share of the diagnoses that occurred among men were related to male-to-male sexual contact. And when you look at women, it was related to heterosexual contact. It's important to remember that we need to keep our eye on one of the risk categories for transmission, which is injection drug use, as we see really a stall in our progress from the perspective of people who inject drugs, and potentially some parts of the country with increases. I want to also focus specifically on data about transgender community. So I will tell you that we have just published one of the most comprehensive surveys of transgender women in the United States to date. And what we found was that 4 in 10 transgender women in 7 major US cities have HIV. And just to review, interviews conducted from 2019 through early 2020 occurred, and it actually included over 1,600 transgender women living in my new hometown, Atlanta, Los Angeles, New Orleans, my old hometown, New York City, Philadelphia, San Francisco, and Seattle. And in that found that 42% of respondents who had an HIV test actually showed evidence of HIV infection. It is important to note from the equity perspective that the survey also found stark racial and ethnic differences in HIV rates among respondents. Nearly 2/3 of Black or African-American transgender women and over 1/3 of Hispanic or Latina transgender women had HIV in this study. At the same time, 17% of white transgender women reported having HIV. So as we think about populations, specifically among Latino Americans, transgender women, though numerically small from the perspective of new diagnoses, represent an emergency piece of our epidemic that requires really urgent focus. I'll say that when you look at the Ending the HIV program, the Ending the HIV Epidemic program, it really is a study in equity. So when you think about equity interventions, it's not about creating equal coverage throughout the country or throughout a geography, but rather trying to focus resources where the epidemiology tells us we need to go and also where vulnerability tells us that we need to focus. When you look at our 57 EHE phase 1 jurisdictions, nearly 2/3 of new HIV diagnoses in 2017 for both Black or African Americans and Hispanic Latinos actually happened in those jurisdictions. So when you disaggregate that further, you'll see that 61% of the new diagnoses among Latinos actually happened in those 57 EHE jurisdictions. So supplementing those areas, supporting them further with EHE funds is really critical in accelerating the end of the epidemic. And again, we're grateful to our to ongoing support of EHE this last year and are looking forward to ongoing support as we hear more about the next budget. Now, just to review, the Ending the HIV plan really revolves around some pretty significant investments. So I'll remind everyone, and I think this is a group that knows all of this, that in January 2020, CDC announced the availability of $109 million in funding for phase 1 jurisdictions to implement what was called disruptively innovative HIV prevention strategies. There are 4 pillars, and the 4 pillars are actually the same pillars that are the core strategies of the Division of HIV/AIDS Prevention at CDC. The first is diagnose. So increasing testing to increase awareness, but also to acknowledge that testing is a critical gateway that really opens opportunities for both treating HIV and prevention. As an HIV clinician myself, I often think that, that the HIV test is a moment of great creation and allows people to take charge of their health in a very important way, whether that is to be treated or to engage in different sorts of prevention. So back to treatment. So again, really working diligently in the second pillar with our colleagues at HRSA to increase rapid initiation of treatment and also maintenance of viral suppression is a critical piece of our strategy that is core to achieving the EHE goals. Prevention. Now, I think that as we, when we think of prevention, very often we go straight to PrEP, and I think PrEP is a really critical piece of our prevention strategy. But as I said on an earlier slide, we can't say PrEP without saying SSP. So syringe service programs are critical, along with PrEP, to really focus on the full spectrum of potential risk for individuals and strategies to prevent HIV. And finally, response is our 4th pillar, which is to empower local jurisdictions to better respond to emerging clusters of HIV infection, which really ends up being this very intensive case management. So beyond the idea of actually identifying clusters, more importantly is it's the edge of the epidemic. And what happens is there at the edge, you often find people who are not being served by treatment or prevention. So the ability to identify these clusters and use our tools and all of our toolkit to interrupt transmission, when we put all of these 4 pillars together into our one strategy, it really allows us, in the absence of a cure or a vaccine, research needs to continue. We know that we can get there to achieve our goal of a 90% reduction in new HIV infections by 2030. I'll footnote that and say, this is really one of the critical pieces of this is that the political will and investment in ending the HIV epidemic needs to continue to be able to achieve the goal. Support for the ending the HIV epidemic initiative has been less than projected. And so we are going to work diligently, and the we is the us, not just CDC, to actually achieve the goal. But part of this is definitely making sure that we keep the eyes on the prize and make sure this is adequately supported to achieve the end. Now it's important to then talk about the challenges, but I don't, and I think Guillermo can vouch for this, I don't like to think about challenges without some solutions. And so I think that there are several challenges that are in the way of us ending HIV, and specifically ending HIV among populations such as Latino Americans. And the first really has to do with equity. Now, I really want to second Joanne Morin's challenge. I think that really it is in all of our universes to try to address the inequality, the stigma, the discrimination, and mistrust of the healthcare system that contributes to the increased risk of HIV among all populations, especially Hispanic and Latinos. I mean, the reality is we are digging out of a hole in terms of the recent history for people who are of Latino origin, in terms of immigration and other challenges that occurred in recent history. So I think that it is not only about public health, and this is where I'm going to give my challenge, which is public health is able to work in health equity to shift the needle, but we need all of us to work in justice. And so it is beyond just fixing some of the health inequities, which we can address by really taking that strategy of that ending the HIV epidemic strategy and other strategies to boost areas and populations that need it. But it really is about looking at the other determinants of health that are the ones that are actually hindering our ability to move from just equity into justice. So that's our first. And I'll tell you that at the Division of HIV/AIDS Prevention, our focus on equity has become razor sharp, both internal and external. And so a great amount of work, including in our reorganization of structure, is to center equity in all we do and make it the dominant feature of all of the work. So you will see more of that to come as we roll out the future of DHAP and our interaction with the community. Now, the other way to deal with the system that's broken is to fix it. And one of the really important pieces of stigma that I think people experience every day is the stigma related to HIV status. And we are responsible partially for maintaining systems that create separate doors for people living with HIV versus for those who are at risk and who could potentially benefit from prevention. Now, they're the same person. Clinically speaking, and from the public health perspective, they're the same people who get HIV were the ones who were at risk. So creating separate environments and separate strategies doesn't really make any sense. That HIV test, that's the gateway. It gets us in the door. If it's positive, people engage in care. They go on treatment if they engage with high quality services, their viral load becomes suppressed and they don't transmit HIV. Similarly, if they're HIV negative and we engage them in high quality prevention services, which is primary care, ultimately what happens is they go on pre-exposure prophylaxis if they need it, and if they don't, it gets reevaluated over and over to see if they happen to need it. And by being on PrEP, they are a lot less likely to get HIV. Why do we have two doors when the care and the services are identical? So you will see in the recent in the very short term future of DHAP a lot of emphasis on status neutral strategies, which are also key to the new federal strategy for HIV in the country. So really the idea of trying to disrupt these doors to come into one door and really embed HIV treatment and prevention services where it should be, which is in the everyday care of a human, not the everyday care of a status. And then finally, one of the things that is so critical in addressing the HIV epidemic is to realize it does not exist in isolation. And so as we work more diligently at CDC on this, you will see more and more efforts shifting into what we're calling syndemic work. This doesn't just mean syndemics of HIV, STI, and viral hepatitis, although those are quite certainly syndemics, but also the syndemics of racism, the inequities of social determinants, the issues around mental health, which our last presenter really pointed out so clearly, and ultimately health equity, which is what all of this is about. And so I think that you will see as we go forward that one of the things that HIV will do is frankly be less greedy and figure out how we can use our own resources with our sister divisions to really push forward the strategy that people don't care where the funding comes from or what the service is earmarked, as long as they're getting good service and it doesn't stigmatize them by making it based on their status. So I think we're going to see some pretty significant shifts as we move forward. And with that, I just want to end by saying I am especially honored to be able to be here today because I am currently not acting as a division director of the HIV AIDS prevention division, but instead I'm the senior lead for equity in COVID data and engagement. And so the work has been inspiring, both taking what I know from HIV, both on the local level and my short time on the national level, but then also learning from COVID ways that we can change how we do our HIV work. So really thinking deeply about vulnerability, thinking deeply about place and geography, and not being blind to ethnicity and color, but rather being very aware of the need to address the disparities and have it be the core of what we do, while realizing that those in public health, we are able to move the needle from the perspective of health equity. It is every part of government and civil society that needs to work together to move us from health equity to the social justice that's necessary to actually make sure that the atrocities that we've seen in this and the last pandemic never happen again. Thank you.
Thank you, Dr. Dimitri, and especially throughout your presentation, but at the end, I truly believe, and I remind people that this global pandemic, when you look at the U.S., Puerto Rico, U.S. Virgin Islands, Washington, D.C., and other territories, it really make more clear something that we have been dealing in so many pandemics, but at the same time, you know, the health inequities and also the whole question of how we look at from the lens of racial and ethnic justice, because it is shocking in terms of the population and then the numbers. And you look at from COVID to HIV to STIs that you are addressing, and how also we can never ignore Puerto Rico. We always need to remind people that the U.S. Virgin Island, Puerto Rico, D.C., they're part of the U.S., and we need to be more mindful how we uplift that. Also, thank you for the CDC and your colleagues for releasing that report and to making more visible the impact on trans. As you know, it's a struggle that we have throughout the U.S. Is how we highlight and make more real the lives of trans communities that have been heavily impacted, both trans men, trans women, and anybody that is of any type of identified on any gender expression is about being visible and being recognized. And we see you, we see Joanne, we see Ivan, we see Dr. Rebolledo as those public health leaders, along with the 192, 208 people in this meeting, that we are committed to change and advance all the challenges that we have. The first question is go to Joanne. Is Joanne still with us? Yes, good. Thank you, friend. Could you share a couple of ideas how best to enhance community-based organizations, community providers to develop a working relationship with city, county, or state health departments?
Absolutely. So first of all, thank you to all of the additional panelists, just amazing presentations. And I think that there are absolute ways, and we've seen such tremendous success in looking at how we partner with all sectors of our community, right? Including the government agencies, both local and state and federal, as well as the other perhaps non-traditional players that we need to make traditional in order for us to respond. I think the one thing that we certainly saw from COVID, in addition to the fact that much of the COVID response is based on the learned experiences of the continuum of care and framework that we have worked to develop over 40 years for HIV, we also learned that in order to do it, we had to have leadership at each and every level of government and community in order for us to get to the point where we're seeing our state reach today. So how do you do this? What you do is you look for opportunities to help facilitate public conversation. You look for the opportunity to send the invitation, right? Because with the invitation comes responsibility. And so when you're holding meetings and you're looking to gain input from across community, include the government agencies in those discussions. If it's a conversation that's not necessarily ready for prime time, if you will, and you're looking to plan, then extend the invitation for those private communications. Prior to coming to state government, I worked in community, and I will say that I can't remember a single occasion in which, when I conducted the outreach, it wasn't accepted, and it didn't lead to positive outcomes. Sometimes it's the first step of doing that. So that's the sort of the smaller suggestion I have of extending the invitation to the dialogue and conversation. But it's also being clear about what it is that you're looking and asking for. A lot of times I know many of the organizations come during legislative session or come throughout the year to talk with elected officials and with government about need. And what I can encourage you to do is, number one, to be sure that you have the data that speaks to what it is you've identified as the gap. Be prepared in short form to talk about what steps you've already taken, and then what the specific things are that you need in order to advance whatever it is that you're trying to move towards. That's what gets attention, and that's what helps people think not so broad that nothing happens, but in a more intentional, focused manner, so that they can leave the table understanding what the expectation is for them to follow up on. And by they, I include myself.
Thank you, Joanne. Moving along to Dr. Ivan Melendez. You still with us, Dr. Melendez Rivera? Yes, perfect.
Yes.
One question from Puerto Rico to all of us. What will be, if you will pick one message for all of us outside the island in terms of how can we best support Puerto Rico when we have a new tenant in the White House, the Biden-Harris administration?
Just one?
A couple.
Well, it's a really hard way to say, because have to be honest, politics is not my straight line of work. But as I mentioned, the way that people can support Puerto Ricans who are outside of the main island, as we mentioned, is providing the same equity of equality, the things that we receive up the island. Usually we are left behind in some of the scene just because we are not living in the main island. Even if you look right now in the 2020 map from the census, there's all the people from the United States, and down is people from Puerto Rico. They are not even include us as part of the United States. And this is just one small sample of the different things that we are not getting as equal as part of members of the United States and equal as a Latinx community as we are.
Excellent. No, I agree with you. That's a fundamental and go across the board. Thank you. Dr. Dimitri, for you, if you could share something about, and again, we're so excited about, your new leadership role, not only within DHAP, the Division of HIV Prevention, but also your new role on COVID. But in terms of a stigma, what you will highlight in terms of all of us in this training institute day one that we can do to intensify addressing something that is so complex and so structural, in any recommendation from you from you?
So I think it's been really interesting actually landing at the Division of HIV/AIDS Prevention and talking about shifting into more of a status neutral space, because I feel like it's one of the most obvious pieces of stigma within the HIV response that actually interacts so closely with racism and homophobia. So I feel like being creative and thinking of strategies of how you can leverage really what you have to actually not just focus on this is for people living with HIV versus this is for those at risk. I feel like when you travel around the country in different parts of different jurisdictions, what you see is that some places can have a big flashing neon sign that says HIV and it works out just fine, but some places really can't. And so really thinking about strategies as we figure out ways that we can better support you from the federal perspective to really smooth over the differences between services for those living with HIV and at risk, it tends to be so intersectional that by actually addressing that piece even a bit, you're able to shift the comfort that people have in receiving services, having conversations, and also engaging in care.
Thank you so much. And again, all of us, just to remind, the challenge put by Joanne, by Dr. Ivan, and Dr. Dimitri about that we need to, reset the button or the lens that we address all these health issues, because we want to be a powerful nation, but also we want to be a healthy nation. And a reminder to all of us, I mentioned to you that we're very proud to be part of Somos Salud, a community-driven initiative under Alianza Americas organization and Ventanilla de Salud and the Commission and the Hispanic Health Network to advance dealing with trust, the lack of trust in the vaccine, but also the lack of trust in our community to access services. And also I want to remind all of us that when we use Hispanic, Latinx, or Latino, Latina, is to try to be inclusive. Because somebody mentioned, I think Dr. Rebolledo, that it's a galaxy. When we talk about Latinos, Latinas, we have folks from Mexican American, Cuban Americans, Dominicans Americans, Central Americans. We need to put it in Puerto Ricans, and then Peruvian, Venezuelan, you name it. We need to go deeper on community mapping and also upgrade or refresh our skills, our knowledge. Starting tomorrow in the afternoon, we will have the educational sessions. We invite all of you to join us, and also remind you that you will be getting in the chat room an evaluation about today's presentation, but also about, in the email, you will get the slides, but also an evaluation on every day between now and Friday to continue giving us feedback to improve the programming. Again, when we talk about prevention and care, prevention is for all. Obviously, some populations are more impacted, some populations have been invisible, and our job is to make them more visible as we can. And we truly believe that we need to increase and address issues like the question that Dr. Ivan Melendez would like to jump in and address.
Yes, there's a question in the chat regarding how to do a PrEP clinic in a rural area. We're going to share one slide that I presented last week in the Office of Regional Operation meeting. Give me 1 second, I think that's okay. Okay, and here you will see it. There's information. There's CDC and prevention funds that I know there's no so easy to get. There's a section 318, and you can use also 340B, that program income that you get for the PrEP medication. Also the Ready and Set PrEP program, which is Get Your PrEP, that provide PrEP medication for free, a third-party billing for the service, because most of the service are paid by third-party billing. And if the site receives Red and White fund, there's a link there of you can go to targethiv.org and put information about Red and White fund for PrEP, and they show how you can carve out for different area of Part A, Part B, or C that can be utilized through PrEP, and also fundraising, donation, or any kind of research program. So there are some of the alternatives that any company, any agency, or institution can use to establish a biomedical intervention clinic.
Thank you, and we will share that slide. And again, I'm grateful with the panelists. I'm grateful with all of you that make the time to join us today. And don't forget that the only way that we're going to be able to change, the challenges, but the solutions, as Dr. Dimitri remind us, is by working together, doing our very best to collaborate, to support each other, and always be mindful about addressing urban, suburbia, and rural realities. They're very different, and we will not be able to do it everything alone, but together we'll make the difference. With that, on the clock, I think, or maybe a minute over, thank you very much. Muchas gracias to the person that do the interpretation. We're very grateful. And again, it's about working together and making the difference. Thank you, everyone. And please be safe and get vaccinated if you can, or motivate someone that is still thinking about it to get vaccinated for COVID and access prevention and care services. Muchas gracias. Thank you, everyone. Love
Bye.
you. Love you all.
Have a good day, everyone.
Thank you.
Bye, everyone. Thank you.